Okay, let's unpack this. We are diving deep into the foundations of obstetrics and gynecology. I mean, this field is so high stakes, it's constantly evolving. And for anyone learning or practicing, knowing these core concepts inside and out is just, it's non-negotiable.
That's absolutely right. We're taking some foundational source material, really high-yield stuff from a core medical textbook. And our mission is to provide you with the essential clinical synthesis.
Right.
We aren't just reading definitions here. We're trying to connect the dots, explain the why behind the screening tests, the treatment mechanisms, and why certain details matter so profoundly in patient management.
And our goal is to give you that truly high-yield study guide, a practical refresh that really cuts through some of the textbook density.
Yes.
We'll be covering everything from, say, calculating a patient's obstetric history to managing surgical catastrophes and common outpatient complaints.
To start any discussion in obstetrics, we absolutely must nail down the foundational language. Gravidity and parity. You'll see it written as the GP system and then the expanded TPL designation.
G and P are the core, but I think people, they often trip over the distinction, especially as the history gets more complex. Can you break down for us what exactly makes parity different from gravidity?
Certainly. So gravidity, or G, is just the total number of times a woman has been pregnant.
Regardless of outcome.
Regardless of outcome, exactly. But parity, P, that only counts pregnancies that reached viability.
Viability is?
We define that as a birth at or beyond 20 weeks gestational age, or an infant weighing more than 500 grams.
Okay.
So here's a key point. If a patient has twins, her gravidity goes up by 1, and her parity also goes up by 1.
Because it's one pregnancy event.
It's based on the pregnancy event, not the number of babies delivered.
That detail is so crucial. And the TPL system, that gives us the full story, right? It lets us stratify risk almost immediately.
Exactly. The TPL breaks down parity into 4 parts.
Okay.
T for term deliveries, so after 37 weeks.
Okay.
P for preterm, which is 20 weeks up to 36 and 6 days. A is for abortuses. And this includes all losses before 20 weeks.
So miscarriages, therapeutic abortions.
And ectopics.
Yes.
And then L is for living children.
Let's run through that key example from our sources just to see how the number is built.
Okay, great idea. So imagine a patient. She had 1 term infant, 1 set of preterm twins, and 2 early miscarriages.
Okay.
Her designation would be G4, P1, 1, 2, 3.
Let's break that down.
4 pregnancies total, that's the G4. Then 1 term delivery, 1 preterm delivery, that was the twin pregnancy, 2 abortuses, and 3 living children.
Got it.
And just to clarify a little jargon, if you hear a patient described as a grand multip, that's a woman whose parity is 5 or greater. And it immediately signals a need for extra vigilance, especially for things like hemorrhage.
So understanding that language lets us start risk stratification from the moment we see the patient.
Precisely.
Speaking of risk, the next step in early pregnancy is screening for genetic abnormalities. How do we approach that today?
Well, the screening options have broadened substantially. In the first trimester, usually between 11 and 13 weeks, we often use the standard combined screening.
And that is?
That's the neutral translucency, or NT, measurement via ultrasound, combined with serum markers.
Right, the PPA and beta-HCG.
Pregnancy-associated plasma protein A and free beta-HCG, yes. The NT measurement is a really key structural marker for risk.
But the newer cell-free DNA testing, cfDNA, that seems to be getting more and more popular. What's the trade-off there?
It is. So cfDNA, which screens for chromosomes 13, 18, and 21, is highly sensitive and specific. It's excellent for those common aneuploidies. But the combined screening, while maybe less sensitive for those specific conditions, gives us that NT measurement.
Which can flag other things.
It can screen for a much broader range of abnormalities and fetal structural issues.
Yeah.
It's an ongoing clinical discussion, really.
And moving into the second trimester, say 15 to 18 weeks, we're relying on maternal serum alpha-fetoprotein, MSA-FP.
Yes, and this is a critical marker that points us in 2 very different directions.
How so?
Well, if the MSA-FP is elevated, we get very concerned about an increased risk of open neural tube defects.
Like spina bifida?
Spina bifida and encephaly, things like that. But if the MSA-FP is decreased, that's seen in aneuploidies like Down syndrome.
Okay.
And to improve the detection rates, we often add beta-HCG and estriol to create the triple screen.
And then there's the quad screen.
Add inhibin A and you get the quad screen. Exactly.
Yeah. Okay, finally in this section, we have to talk about one of the most serious emergencies in early pregnancy. Ectopic pregnancy. The incidence is rising too now, over 1 in 100 pregnancies.
An ectopic implantation is It's a ticking clock,
Mm-hmm.
especially if it's in the fallopian tube, which is where it is 95 to 99% of the time.
And usually in the ampulla, right?
The most frequent site is the ampulla, about 70% of the time.
Mm.
And you can see why. That's where fertilization often happens. The tubal wall is thin, and as that pregnancy grows, rupture becomes imminent.
That rupture is what elevates this from a complication to a full-blown catastrophe.
It is. And we need to know the risk factors cold. Any history of STIs or pelvic inflammatory disease.
That damages the tubes.
That damages the structure. Also, prior tubal or pelvic surgery, endometriosis, IVF, IUD use, smoking, all of them. A ruptured ectopic pregnancy causes rapid, life-threatening hemorrhage and shock.
And the stats are stark.
It's tragically responsible for 6% of all maternal deaths in the U.S. That is the gravity we're dealing with.
Let's shift gears and look at how we screen for some foundational autosomal recessive disorders, specifically cystic fibrosis and thalassemia.
Okay, focusing on cystic fibrosis first, the pathology lies in the CFTR gene.
The chloride channel regulator.
Exactly, the transmembrane conductance regulator. When that gene is faulty, you get these thick secretions that impact multiple organ systems. For any autosomal recessive disorder, you need 2 mutant copies to be affected.
And you mentioned there are different ways to get those 2 copies.
That's the subtlety, yes.
Yes.
An individual can be homozygous, meaning 2 identical copies of the same mutation.
Oh.
Or, and this is much more common in the real world for most of these disorders, they can be compound heterozygotes.
Which means?
2 different allelic mutations on the same gene, but both of them cause disease. And given the high carrier rate in Caucasians, something like 1 in 25 to 29, the challenge is screening for I think it's over 1,300 known mutations now.
Wow. Okay, now thalassemia, that's all about hemoglobin chains.
Correct. Thalassemias are hereditary hemolytic anemias. They're caused by reduced synthesis of either the alpha or the beta globin chains.
And that creates an imbalance.
A big imbalance. The alpha-beta ratio gets distorted. The unpaired excess chains then precipitate, and they physically damage the red blood cell membrane.
Leading to hemolysis.
Leading to hemolysis, premature destruction, yes.
So how do we differentiate and screen for the 2 main types?
Well, beta thalassemia is an impairment of beta chain production. It's more common in Mediterranean, Asian, and African populations. Screening starts with a simple CBC.
Looking for a low MCV.
A low mean corpuscular volume, yes. Usually less than 80. Confirmation then comes from hemoglobin electrophoresis, which will show an increased level of hemoglobin A2.
And alpha thalassemia is the one that can have that absolutely catastrophic fetal outcome.
It is. The alpha chains are encoded by 4 alleles, not 2.
Right.
So deletion of 3 or 4 of those genes causes the severe phenotype. Deleting all 4 means the fetus just can't produce functional hemoglobin.
And that leads to?
It results in hydrops fetalis, it's typically incompatible with life. The fetal hemoglobin electrophoresis would show 90 to 100% hemoglobin BART.
Let's move on to fetal growth. We hear small for gestational age, SGA, and intrauterine growth restriction, IUGR. What's the fundamental clinical distinction that drives how we manage them?
The distinction is vital. SGA just means the fetus is small, maybe constitutionally small.
Just a small baby.
Exactly. Below the 10th percentile, but no known pathology. IUGR, however, explicitly implies a pathologic interference with growth.
And that changes everything.
It changes everything. An IUGR diagnosis mandates accelerated surveillance. An SGA fetus might just need routine monitoring.
The pathology is also defined by the timing of the insult, isn't it?
Yes. Before 20 weeks, fetal growth is mainly hyperplastic. Cell number is increasing.
So an early problem.
An early insult often causes symmetric growth restriction. The whole fetus is proportionally small. After 20 weeks, growth as hypertrophic cell size is increasing. A late or prolonged insult leads to asymmetric growth.
That's the more common one.
About 2/3 of cases, yes. And the key mechanism there is brain sparing.
Blood gets shunted to the brain.
Preferentially shunted away from the body and toward the brain. This leads to a disproportionately large head circumference compared to the abdomen.
And since fundal height isn't very precise, how do we effectively monitor these high-risk IUGR babies?
We rely heavily on advanced ultrasound, primarily umbilical Doppler velocimetry.
Okay.
We're measuring resistance in the placental circulation. As the placenta fails, resistance in the umbilical artery goes up and diastolic flow goes down.
And the critical sign is?
The critical sign is absent, or even worse, reversed end diastolic flow. This is highly predictive of a poor outcome. It suggests the fetus is acidemic, in distress, and delivery is usually warranted.
On the other side of the spectrum, we have large for gestational age, LGA, and macrosomia.
Right. LGA is an estimated fetal weight above the 90th percentile. Macrosomia is clinically defined by ACOG as a birth weight over 4,500 grams.
And the risks here are mostly mechanical.
Largely. Increased risk for birth trauma, most notably shoulder dystocia and then brachial plexus injury, but also neonatal metabolic risks.
Like what?
Hypoglycemia and polycythemia are the big ones.
Let's close this segment on some critical maternal infections, the TORSAGE acronym focusing on vertical transmission and management.
Okay. CMV, cytomegalovirus, is the most common congenital infection overall.
And the leading cause of?
The leading infectious cause of congenital deafness. The severity of transmission is much higher with a primary maternal infection.
And symptomatic infants present with?
They can present with what we call cytomegalic inclusion disease. Hepatosplenomegaly, cerebral calcifications, microcephaly, the classic triad.
And for syphilis, the management takeaway is completely unambiguous.
It is. Syphilis, caused by Treponema pallidum, leads to severe outcomes, especially with primary or secondary maternal infection. The high-yield takeaway, the thing you have to know, is that penicillin is the only treatment with proven efficacy in pregnancy.
For both mother and fetus.
For both. So if a pregnant patient has a documented penicillin allergy, you can't just give her something else. She has to undergo inpatient penicillin desensitization to get the required treatment, period.
As we move into labor management, we should clarify two similar but distinct processes. Induction versus augmentation.
Yes. Induction is the deliberate initiation of labor before it starts on its own.
So using prostaglandins to ripen the cervix?
Right, or a balloon catheter or an IV oxytocin drip, often combined with an amiotomy.
And augmentation?
Augmentation is when the patient is already in labor, but contractions are inadequate.
The labor has stalled.
It's stalled. So we use oxytocin or amiotomy to treat that prolonged phase. We can assess it by cervical change or, more precisely, with an intrauterine pressure catheter.
You mentioned amniotomy or breaking the water. That carries one pretty significant sudden risk.
It does. When you rupture the membranes, especially if the fetal head isn't well engaged in the pelvis, there's a serious risk of umbilical cord prolapse. The gush of fluid can pull the cord down past the baby's head, which is an emergency because it cuts off oxygen supply.
I have to be careful.
Very careful not to unnecessarily elevate the head when you do it.
Now for what might be the most feared obstetric catastrophe, uterine rupture.
This is a devastating event. And the primary risk factor, overwhelmingly, is a prior uterine scar.
From a C-section.
A prior cesarean. The overall risk of rupture during a trial of labor after cesarean, or TOLAC, is actually quite low, about 0.5 to 1.0%.
But that's not for every type of scar.
No, that is the key. If the patient has a prior classical incision, that's a vertical cut through the contractile upper part of the uterus TOAC, is highly contraindicated. The rupture risk just skyrockets.
The signs of rupture, they sound incredibly dramatic in a clinical setting.
They are. You're looking for a sudden onset of intense, tearing abdominal pain. This is often accompanied by a non-reassuring fetal heart rate tracing, the abrupt stop of contractions.
And the mother can feel it.
The mother reports sensing a pop. When you suspect rupture, there is no time to waste. It requires immediate exploratory laparotomy.
Shifting to delivery outcomes, we also need to be precise about the degrees of perineal lacerations. This really dictates the repair.
Completely. They're classified entirely by depth. A first degree is just the mucosa or skin.
Okay.
Second degree extends into the perineal body, but stops before the anal sphincter.
The muscle.
The muscle. Third degree extends into or completely through that anal sphincter muscle. And the most severe, fourth degree, means the anal mucosa itself is entered.
And the clinical takeaway there?
Mandatory rectal exam. After every perineal repair, you must do a rectal exam to make sure you haven't missed a subtle fourth-degree tear.
Postpartum hemorrhage, PPH, is the leading cause of maternal morbidity. The 4 T's mnemonic is helpful, but let's focus on the first two. Tone and tissue.
Right. Tone, or uterine atony, the failure of the uterus to contract, is the most common cause by far.
Okay.
But when that atony is unresponsive to our first-line therapies, uterine massage, oxytocin, prostaglandins,
then you have to think about something else.
You must immediately suspect a tissue problem, an abnormality of placental adherence.
And that leads us straight to the pathology of placenta accreta.
Accreta is the abnormal adherence of the placenta to the uterine wall. If it invades deeper into the myometrium, it's increta, all the way through to the serosa or even into the bladder. That's Procreta.
And the risk for this goes up dramatically with prior C-sections, especially with a placenta previa.
The combination is the real danger. The risk jumps from about 3% with one prior C-section up to 67% with 5 prior sections. It's a staggering increase.
So if the risk of Accreta is that high, what is the single most important clinical action we need to take before the delivery even begins?
Pre-delivery interdisciplinary planning. That's it.
Okay.
Understanding this pathology fundamentally changes your entire preparation. You have to anticipate a massive hemorrhage. You need transfusion protocols ready. You often need to involve vascular surgery, urology, anesthesia in the planning for a controlled delivery via laparotomy and, likely, a hysterectomy.
Okay, finally, let's look at contraception for the postpartum patient who's breastfeeding.
Right. Here we prioritize progesterone-only methods.
The mini pill, Depo-Provera.
The mini pill, Depo-Provera injection, or the LNG IUD. This is because the estrogen in combination pills can actually suppress prolactin, which can lead to a decrease in milk supply.
And the progesterone-only options don't do that.
They're shown not to impair lactation, which makes them the preferred choice for breastfeeding women.
Let's move to common gynecologic conditions, starting with vulvovaginal dermatosis. We need a clear way to distinguish between lichen sclerosus and lichen planus.
They're often confused, but they have distinct presentations. Lichen sclerosus, or LS, is characterized by white, thin, scarring skin, typically on the labia and perineum.
But not inside the vagina.
It does not involve the vagina, and it can cause architectural changes, like resorption of the labia minora. The treatment is a high-potency topical steroid, like clobetasol.
And lichen planus?
Lichen planus, or LP, is an erosive disease. It presents as red, shiny papules and erosions, often with white streaks. Crucially, LP can involve the vagina and cause vaginal adhesions.
Okay, next, the very localized complaint of Bartholin's cysts and abscesses.
These are located at the 4 and 8 o'clock positions on the labia majora. A symptomatic cyst or abscess needs an incision and drainage, an IND.
But they tend to come back.
They do. Simple IND has a high recurrence rate, so we either place a word catheter or perform a marsupialization to create a permanent draining tract.
And there's one critical high-yield fact for older patients.
Yes. For any new cyst that appears in a woman over 40, a biopsy is mandatory. You have to exclude the rare but serious Bartholin's gland carcinoma.
We also have to address amenorrhea, distinguishing primary from secondary.
Primary amenorrhea is the absence of menarche by age 15 in someone with normal secondary sexual characteristics. Diagnosis follows a flowchart.
Looking at presence of uterus, breasts.
Exactly. Looking for genetic or congenital causes like Müllerianogenesis. Secondary amenorrhea is the absence of menses for 3 months in someone with regular cycles, or 6 months if they were irregular.
And the first test is always...
The single most important test to rule out first is always pregnancy. Get a serum beta-HCG.
And after that?
Other causes. Hyperprolactinemia, Asherman syndrome, which is intrauterine adhesions, and hypothalamic hypogonadism, which we see in high-stress athletes or patients with eating disorders.
Let's close with infertility, where polycystic ovarian syndrome, or PCOS, is the most common ovulatory factor.
Right. Initial management for PCOS often starts with lifestyle modification. We know that even a 5% weight loss can be enough to restore spontaneous ovulation in some patients.
And pharmacologically.
We use metformin and then ovulation induction, or OI, with agents like clomiphene citrate or letrozole.
Can you explain the mechanisms of those two? Because they work through entirely different pathways.
They do. Clomid is a SERM, a selective estrogen receptor modulator. It competitively binds to estrogen receptors in the hypothalamus.
So it blocks them.
It blocks the negative feedback that estrogen usually provides. The brain perceives low estrogen and responds by pumping out more GnRH, which boosts FSH and LH, stimulating follicular growth.
And letrozole.
Letrozole is an aromatase inhibitor. Its job is to decrease the conversion of androgens to estrogens.
So it lowers estrogen levels directly?
It lowers the circulating estrogen, which also results in the pituitary increasing its FSH output to promote follicular development. So 2 different paths to the same goal.
And when treatment progresses to assisted reproductive technology, RT, the main complication we see is it's a numbers game, isn't it?
It's a volume problem. The major complication of RT is multiple gestation pregnancies. Studies, even from a decade ago, showed the rate of multiples from IVF was around 31%.
And that carries huge risks.
Significant maternal risks like PPH and preeclampsia, and significant fetal risks compared to singleton pregnancies.
So we've really navigated the core concepts of OBGYN, focusing on that clinical application. from the TPL system to, the cellular mechanism of how a SERM works. We've highlighted how crucial it is to understand the underlying physiology, like why high progesterone in pregnancy causes constipation, it decreases bowel motility, or why managing PPPROM, premature rupture of membranes, shifts so dramatically at 34 weeks.
Right, because the risk of infection then outweighs the risks of prematurity.
Exactly.
This all raises an important forward-looking question for you, for the learner. Given the rising rates of prior C-sections and the associated risk of abnormal placentation like accreta, how does knowing the full pathological spectrum creta and creta prequita fundamentally change your readiness and planning for every single high-risk delivery you encounter? The scale of potential hemorrhage requires a whole different level of foresight.
That's a great point. And to reinforce the core language we started with, here's a quick review exercise for you to complete on your own. A woman's chart reads G3P1011. What does her parity designation immediately tell you about her prior pregnancy outcomes? And what common complications should you be prepared to screen for in her current pregnancy?
Use these key points as building blocks. Synthesize the connections between the pathology and the management. That is where true clinical knowledge lives. Keep diving deep.